The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast. In part one of this episode with Drs. Newcomer and Fields, we learned about the evaluation, staging, and initial treatment considerations for cutaneous melanoma, including initial excision techniques and discussion of some of the most important sentinel lymph node trials. Now, on to part two of this episode, which will focus on additional aspects of the care of cutaneous melanoma.
So just a few things that follow-up questions that I would ask about your practice patterns that might help our residents when they're seeing patients in the clinics and on board exams. Does the primary tumor size or the T-stage affect your management of an occult micrometastatic disease? For example, somebody with a 1 millimeter primary with occult nodal mets compared to an ulcerated 5 millimeter primary?
Yeah, I think the ulceration, like we talked about in Breslow depth, really drive prognosis to some degree. So what that would probably do more in this day and age, and we haven't touched on this yet, is it would probably lead towards recommending adjuvant therapy after their staging with wide excision of sentinel node, because by definition, if they're ulcerated and they have a positive node, they're going to be 3B or higher, where their risk of recurrence if we do nothing is can get up to 50%. So then we say, well, can we do anything now in the adjuvant setting to reduce that risk? And fortunately, with immune therapy and targeted therapy, there is, and the risk reduction is usually 50% or greater. So we can take someone's risk who's 50% and drop it to 25% ish. So it would really drive the next steps.
And how about the size and the number of occult positive tumor deposits? For example, would you consider a 0.2 millimeter isolated tumor cell deposit to be different from a 2 millimeter micrometastasis, like has been suggested in some other tumors?
Yeah, and that's been borne out in the trial. So if you really look at one of the tenets, I think that any trainee should take in interpreting data is you want to make sure that the patient population from the trial is relevant to the population that's sitting across from you in clinic. And so for most of the adjuvant trials, say for melanoma, they took patients that were 3A, but most of them had to have at least a millimeter of micrometastasis, so not submillimeter, not isolated tumor cells. So the greater the burden of the metastatic disease, the greater the stage and the greater the risk of recurrence. So that would certainly drive the use of adjuvant therapy. The other thing that we haven't mentioned, it's not used that often, but radiation can be used as adjuvant therapy in melanoma. There is a good randomized trial looking at using adjuvant radiation. It was done in exactly the patient population you're talking about, which is higher burden of disease in the after sentinel lymph node biopsy or completion lymph node dissection. The reason it's fallen out of vogue a bit is because of how powerful the immune therapies and targeted therapies have become in the adjuvant setting, and because the morbidity of a completion node dissection plus radiation is even higher in terms of the risk of lymphedema and wound complications.
And the last question I have is about, in your practice in the current year, are there any patients that you would recommend an upfront therapeutic lymph node dissection? And I guess that also serves as a segue into patients that might be eligible for neoadjuvant therapy. Yeah,
and this is probably the biggest paradigm shift in melanoma that's gone on since this concept of adjuvant therapy or completion lymph node dissection omission, and that's neoadjuvant therapy for patients that present with upfront stage 3 and 4. So this would be clinically occult or radiographically occult stage 3 or 4 disease at the time of diagnosis. And there's 2 trials, the Prado trial or study, and more robustly the SWOG 1801 study that are probably the newest and greatest. And as an example, SWOG 1801 said, let's take patients that we were going to put on adjuvant therapy anyway. So these would be patients that present with stage 3 disease, where normally the paradigm was resect all the disease and put them on adjuvant. Let's just take 2 doses of their total therapy, and instead of giving them in the adjuvant setting, give them in the neoadjuvant setting. 2 doses, just 2 doses. Same therapy, just shifted. And the overall survival benefit was huge in just those additional 2 doses. And the pathologic complete response rate was over 10%. It was close to 30%. So now we're saying we can actually just give 2 doses of immune therapy and get these major pathologic responses. And the reason the translational scientists and the immunologists think that this works is because when the tumor is present, the immune therapy works better because the T cells, if the analogy is an army, the T cells kind of see the tumors at that time, and the immune therapy stimulates them to fight against that tumor. If you take the tumor out, the army doesn't know what to go fight against. So although the immune therapy works, it doesn't work as well. It's not a perfect analogy, of course, but it's kind of the idea of the immune system works best when it's got something to fight against, not when it's kind of sitting back waiting for something.
And then moving ahead now to the completion lymph node dissection, if this is indicated for your patient, do you mind just quickly reviewing the complications of those procedures, the reasons that we're excited to avoid them in patients that don't need it?
Yeah, and the most common clinical scenario now where we're doing completion lymph node dissections would be someone who goes on adjuvant therapy but then develops nodal disease, or that's on surveillance and then develops nodal disease. So we still do it not infrequently, but it's usually in the presence of known disease. The number one complication for most feared complication after a lymph node dissection is going to be lymphedema. Lymphedema can be defined a lot of ways, so I think the most important way to think about it is lymphedema that alters what a patient can and can't do. Meaning if I take a tape measure on everybody that I've ever done a lymph node dissection on and measure their detailed by the millimeter limb circumference before and after, they're going to have a little bit of swelling that's measurable, but most of the time it's not functionally altering at all. But in about 10 to 15%, you can get functionally altering lymphedema that does affect what they can and can't do. Lymphedema is the type of complication where if it gets bad, it's hard to reverse without serious interventions like lymph node revascularization. But if you notice it early, if it starts happening early, you can do a lot of things to prevent it from getting worse. Things like wearing compression garments, lymphedema pumps and massage therapy, things like that. And education goes a long way for lymphedema prevention, because if patients can protect their arms more, say, for example, they're into gardening, well, we always want them to protect their hands. Minor scrapes and cuts are different in an arm that's undergone lymph node surgery, or a leg, that sort of thing. That's the number one complication. Then we talk about wound complications. They are certainly higher in the groin than in the axilla, than in the head and neck, but wound complications are an issue. Most of the time after a lymph node dissection, we also leave a drain. The drain usually needs to stay in a few weeks, but there can be long-term lymphoceles and seromas that need to be managed by sclerosis and interventional radiology. And so those are major considerations. All these wound complications and lymphedema are magnified by presence of uncontrolled diabetes, by smoking, and by obesity. So there are modifiable risk factors that can be used and optimized to reduce some of those risks in a lot of kind of prehabilitation strategies as well.
When it comes to lymph node dissection, I think surgery residents will be most familiar with axillary dissections. And we talk about the injuries to the intercostal brachial nerve, long thoracic nerve, thoracodorsal nerves that can happen during that operation. I think that will be covered during the breast cancer podcast and in that chapter. But could you just quickly highlight some differences between an axillary dissection for melanoma and one for breast cancer?
Yeah, I would say especially because of many patients that receive surgery for breast cancer nodes are also going to undergo adjuvant radiation and further adjuvant therapy. Sometimes it's a little bit of a different approach to that operation, a little more selective, I might say. For melanoma, it's usually a complete levels 1, 2, and 3 axillary lymph node dissection. So a lot of times you might get asked, well, what are the boundaries of your dissection? You're going to try to stay on top of and then inferior to the axillary vein. You're going to go down to the latissimus laterally into the chest wall or serratus medially, and you're going to continue the dissection underneath the pectoralis all the way over, if you can, to the sternum. In a really big patient, sometimes that means dividing the pec minor, but oftentimes with good retraction of the pec muscle, you can get under the pec minor without dividing it and clear all those lymph nodes. And then inferiorly, you usually are tracing the thoracodorsal bundle down to where it inserts into the latissimus and continue the dissection to that level inferiorly. For a woman, that usually means just getting into the axillary tail of the breast or right at that level. For a male, you may not see that transition as much, but again, where the thoracodorsal nerve comes in. And if you clear out all the soft tissues in that space, sparing the nerves and the lymphovascular structures that you mentioned, that would be a complete levels 1 through 3 axillary lymph node dissection for melanoma.
Moving on now, we have sort of hinted at the topic of systemic therapies in melanoma used in the adjuvant and the neoadjuvant setting. Let's briefly talk about them in a little more detail, just starting with targeted kinase inhibitors. The BRAF oncogene being activated in about half of melanomas is a therapeutic target now often used in combination with MEK inhibitors. I've heard that these agents are pretty highly effective in the short term, but are susceptible to resistance and recurrence. Has that been your experience in your patients?
Yes. So if you take the concept of targeted therapy, where roughly 50% of melanomas will have a mutation in the BRAF gene, and most of them are in the same kinase domain, a V600E mutation, valine for glutamic acid. There are V600K mutations as well. It doesn't really matter where the mutation is. If they have that mutation, then they're a candidate for BRAF targeted therapy. Initially, it was BRAF targeted therapy alone. The addition of MEK inhibition is more effective, kind of like combination antibiotic therapy. It works better. It targets resistance pathways. In general, almost every patient's going to respond. If you have the mutation, you're going to respond to the therapy. Everybody will develop resistance over time. And that's a paradigm that, as a trainee, you can think about for any targeted therapy, whether you're talking about GI stromal tumors and KIT inhibitors. For melanoma, the BRAF MEK combination will generally have a 9 to 12 month effective period, and that's in the metastatic setting. It's been tested in the patients that are stage 3 patients after wide excision sentinel node as adjuvant therapy in patients with BRAF mutated melanomas, and it's effective in the adjuvant setting as well. So it's a highly effective therapy. In the metastatic setting, it has a limited lifespan.
And then I think it's also important that we quickly review checkpoint blockade immunotherapy, which also has very dramatically changed the way that we treat melanoma patients. The PD-1 receptor and its ligand associated with T-cell senescence and deactivation is an important target with drugs like pembrolizumab and nivolumab. CTLA-4 and its monoclonal antibody ipilimumab is another example involved in co-stimulation of the T-cell receptor. It seems that the PD-directed therapies as monotherapy in the right patients are the first line per the NCCN, and that combination therapy with PD and CTLA-4 or even new targets like the LAG3 gene are used in patients that have a higher burden of disease at the expense of greater toxicities.
Yeah, what's been exciting is probably by the time this podcast airs, there will be a new regimen, a new target. That's how quickly this field is evolving. If we sort of say you present with stage 4 melanoma, the standard of care is going to be starting off with immune therapy. It wouldn't be wrong to start out with targeted therapy, especially in a highly symptomatic patient, because you're going to get a quick bang for your buck. So the example I often use is, let's say somebody presented with a horrible tumor encroaching on their brachial plexus, and they were just having a terrible time with that, and they were BRAF mutated. You might start them right away on BRAF MEK for even just a couple months to give them symptomatic relief and then transition them to immune therapy. But most patients, if they're not horribly symptomatic like that, you'd start out on immune therapy because the durability of effect is going to be a lot longer, and you save the BRAF therapy if they're mutated for potential recurrence. The standard of care for a high performance status patient would be either anti-PD-1 therapy or anti-PD-1 plus anti-CTLA-4 combination therapy. You get a little bit more bang for your buck, but the toxicities are higher. And then you mentioned we have our newest FDA-approved agent that targets the LAG3 pathway, Opdualag, which is approved for patients that progress on PD-1 therapy. But there are studies now just coming out that will mature pretty quickly of combination PD-1, LAG3, all the combinations you can imagine. So it becomes exponential. We had 2 agents. There's only so many combinations of 2 agents. Now we have 3. You can, as you get more and more. And what people like to talk about is this immunologic synapse between the T cell and the tumor. But if you can think about it, now there's people doing work in B cell related therapies or B cell immunotherapies. There's TIL-based therapies. There's now an FDA-approved cellular therapy for melanoma that involves harvesting a lymph node or a metastasis from a patient, growing up the tumor-infiltrating lymphocytes that are in there and giving them back to a patient. That's a newly FDA-approved therapy. So the landscape of immune therapies is ever evolving and moving in a direction where we're overcoming resistance mechanisms, identifying new resistance mechanisms, and bringing them back to the lab for the next generation of therapies.
I think the last thing I want to mention about melanoma is postoperative surveillance, which I think is another thing that to always keep in mind for trainees. What is your general post-op surveillance plan for folks with stage 1 or 2 melanoma?
Yeah, so there's the caveat for this is there's no randomized data, level 1 data to really guide this. But if you look through guidelines, you also talk to patient advocacy groups of what patients want, and you kind of think about what's practical, is I generally will take patients that have had resected melanoma that are in surveillance, and I will recommend that they see me and their dermatologist alternating every 6 months for at least 2 years, and then we can space out the visits so they're seeing their dermatologist once a year and me once a year, staggering them for years 2 to 5. And then when we get out to 5 years, I usually will stop seeing the patients, and so long as they're under the care of a good dermatologist. And the reason for that strategy is initially the patients will have some risk of recurrence of the melanoma that I treated them for. And so focusing on that area and a good lymph node examination makes sense. But once you get to 5 years, that drops off to very low. The main reason, probably the driving reason for long-term follow-up is that if you have had one melanoma, your risk of developing another melanoma or concerning melanocytic lesion like a melanoma in situ over the course of your lifetime is going to be about 6 times higher than the general population. So we generally recommend long-term follow-up because if something else pops up, we'd like to catch it early. So that's where the dermatologist comes in, and of course you as a surgical oncologist can do a good skin exam as well. For patients that have large numbers of cutaneous lesions that's just hard to follow clinically, there's a lot of new things coming along related to total body photography and using pattern recognition, artificial intelligence, machine learning to then compare scans from one visit to another to target biopsies and follow-up of concerning lesions. And then there's all sorts of things now that are coming hot off the press related to monitoring people with circulating tumor DNA and things like that for surveillance protocols that are on the horizon.
Well, Dr. Fields, I thank you very much for going through that melanoma case with us. Your expertise is very much appreciated in that field.
We hope you enjoyed this installment of the Washington Manual of Surgery podcast. Stay tuned for part 3 of this episode, which will delve into non-melanoma skin and soft tissue tumors, including the management of soft tissue sarcomas. We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.